Thanks, everyone. We'll get started. I just wanted to begin today by welcoming you to our webinar, Meaningful Partnerships with Mental Health Consumers and Carers, Strengthening Research and Clinical Care. Delighted to be joined by two speakers today, Professor Graham Meadows and Dr. Michelle Kehoe. Before I introduce Graham and Michelle, I wanted to take a moment to acknowledge the traditional custodians of the land on which we're meeting today. And in a spirit of reconciliation, I offer my respects to elders past, present and emerging. And I also pay those respects to any Aboriginal and Torres Strait Islander people who are joining our webinar here today. We're delighted to have our speakers here presenting Professor Graham Meadows. Graham has been a very prominent figure in mental health care, clinical care research and evaluation for many, many years now, is an academic at Monash University and has done leading work around GP shared care, resource distribution, applications of mindfulness in clinical mental health practice and recovery-oriented practice. Most interest, Graham, is that it has a very long, many, many years of experience of involving people with a lived experience of mental health conditions in his research and evaluation work in clinical care. I'm delighted to have you here today, Graham. And also Dr. Michelle Kehoe. Welcome, Michelle. It's terrific to have you here as well. Michelle is a lecturer in psychology in the Occupational Therapy Department at Monash University, and she also works in the area of evaluation and research development at Alfred Health in child and adolescent mental health. She completed a PhD in 2018 looking at social and emotional learning in young people and has worked in research for over 15 years now, primarily developing and conducting research programs on mental health programs for adults and young people, including a program that she and Graham will present on today. She's also led work where she's been a consumer researcher as well, and she's a keen interest in evidence-based interventions. Graham and Michelle, welcome and thank you. And over to you. Everyone will have a presentation now by Graham and Michelle with some time for questions at the end. Thanks so much, and over to our speakers.
Thank you, Angela, and thank you for the invitation to take part in this. And I think it's thank you also for the acknowledgement of country on our behalf. And I think there is a parallel, particularly perhaps for those of you who are not in mental health here, about the fact that we do that acknowledgement of country for a range of reasons, but that includes the fact of the acknowledgement of the abuse and damage that was done to such a great degree to the Indigenous population of this country, and in that context, that there is a parallel here with the way in which participation and partnership and collaboration with consumers has come to be such a part of mental health care over the years, in that it grows in part out of that sense that much of mental health care, whatever its intentions were at the time, has been subsequently recognized and currently recognized as carrying harms of institutionalization, harms and damage from coercive treatments. And so there is, in the same way that there is an acknowledgement and an invitation into partnership from people of Indigenous backgrounds, there's an imperative for us in mental health to do something which conveys, as among other things, some of that kind of repairing process with consumers in relation to mental health care. And as Angela introduced, this is something that I've been involved in one way or another. I was reflecting the other day, for about 35 years. So really through the length of my clinical career and academic career in mental health care. But the particular project that we are going to talk together about in today's session, which related is this thing called the Pulsar project, which has a history that goes back about 12 years, and in that it really started off with a conversation in London in 2011 with a London researcher called Mike Slade. And for those of you who are interested in research output, the primary outcome paper that we produced from this was published in 2019 in The Lancet Psychiatry. And I guess one of the things about this was that this was the outcome of several years of work based around a large grant. This grant was of itself unusual. It was very strongly oriented towards aligning with contemporary developments in mental health care in Victoria. It was a state government grant, and this was intended to fund a small number of big grants that would produce some useful and relevant outcomes. And so this was, the grant process did, right from the start, involve consumers in the process. One of the lead investigators on it, also an author on the first paper, was Vrinda Eden, who was the lead of consumer care relations in Monash Health at the time. And so, along with a range of experts from a wide range of institutions, both academic and service, we also very clearly had a very strong presence from the start of consumer involvement acknowledged by the investigator presence. And so Pulsar stood for Principles Unite Local Services Assisting Recovery. And recovery has a particular meaning, as many of you will be aware, in the mental health context. It's something which really emerged originally from consumer advocates such as Patricia Deegan, and came about as in some respects a rejection of, reaction against the way that clinicians were seen as overly focusing on diagnosis and treatment and problems, and a request, a push to do things and frame the process of care and help rather differently. But having done that brief introduction, Michelle, let me just ask you to make one or two comments on what recovery is.
Sure, thanks, Graham. I'll tell everybody a little bit more about my involvement in the project a little bit further on in our presentation. But when I first joined the project, which, as Graham mentioned, was about 10 years ago, I didn't even know that recovery was a thing. I just knew that I was having mental health issues, and I didn't think that they would ever be cured, for want of a better word. But I think what I've learned through my involvement with this project, and also subsequently, that recovery is 100% possible, but it's very different for everybody. And so I think it's really difficult to define what recovery actually means, because everyone's journey is very different. And often I think when we think in academic terms, or we think in clinical ways, we often think of like it being a linear, everything is a linear process. You give a person a tablet and it fixes them and off they go. Whereas with mental health recovery, I see it as being like a bowl of spaghetti, and it's all jumbled up, and you don't know if you're going to get to the end of the spaghetti, or you don't know what your journey is going to be to get to the bottom of the bowl. And that's what mental health recovery is. It's different for everybody, and it's up and down, it's backwards and forwards. But regardless of what that journey is, there can be an endpoint, and that endpoint would be different for everybody. And that endpoint is whatever it means to that person to have a different life, a better life, go back to their old life, whatever life they choose to accept and acknowledge at that particular point in time. That was a very long-winded explanation, Graham, so I'm going to hand back to you.
Yeah, all right. Look, thank you, Michelle. And I mean, I think a key point about this is that, obviously, that there are branches of medicine in which pharmaceuticals or surgical interventions are incredibly powerful. My experience as a clinician in mental health care was that it was very, 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 very rare to encounter someone in clinical practice for whom prescribing a drug sorted the problem out. Once or twice I'd seen it, but almost always you've got other things to sort out: psychological, psychosocial, and environmental relationships. And really a lot of that relates to the broad concept of recovery, which has become to be seen as vitally important in contemporary mental health care. It's something that initially arose as a consumer movement, and then in a sense has been in some respects, you know, brought into, some might say taken over, but it's certainly something that has become part of practice and part of legislative frameworks. This particular project was originally inspired by some British work. This was a study called Refocus, which was underway in 2011 when I met with Mike Slade in London. And they had taken a lot of the kind of concepts of recovery. This team of psychologists and lived experience workers and researchers had taken this concept of recovery and done lots of literature searches about it and worked their ideas up and come up with something which was a package that could be delivered to mental health care staff to help them work more in this kind of way. And they at the time were researching that, and we took this on as part of the basis of what we then went on to do in Pulsar. One of the things that they were also doing in the course of that was looking at a range of documents that had been written broadly about recovery and doing actually a thematic analysis of these documents, coming up with this very nice acronym of CHIME, Connectedness, Hope, Identity, Meaning and Purpose and Empowerment, which has a range of other ramifying meanings as extracted from the literature. But one of the things that was a feature of this in terms of bringing some of these ideas into routine clinical care was the use of of snappy little mnemonics that are useful, that enable people to hold the concepts in place as they're doing things in the moment by moment bustle of clinical and other work. This is a summary of the findings from the study that they were doing when we got to know them in London. And the key thing about this was that the Refocus intervention, which used this manual, used some training, actually kind of overall didn't show a positive primary endpoint. They did some secondary analyses that showed that higher adopting teams did a bit better, but the overall study was negative. For research nerds, we did a whole lot of things very differently in Pulsar, and we developed and iteratively refined the design of the project. This was a very the original Refocus design was a parallel groups cluster randomized control trial, which had certain restrictive recruitment criteria. We turned this into a step wedge with serial cross-sectional studies at different time points, and with a number of other features. And one of the other things that we did was we very much emphasized co-delivery of all of the training. So for the entirety of the training, there were always in the training space, leading the training, both someone with lived experience and also a professional. So the overall essence of it could be summarized in these acronyms: CHIME, REACH, some specific working practices. The design, as I said, was a mixture of complete and incomplete step wedge design. And this was interesting in as much at the time we actually put the study in, we didn't define it as a step wedge study, because at the time the sort of understandings and the methods of step wedge designs were still developing. For those that don't know about step wedge designs, it's a question that, you know, in a parallel groups design, people around the groups or clusters are randomized to whether they get the intervention or not. In a step wedge design, they're randomized to time in which they get the intervention. This is the simplest possible step wedge design, which means that you either get the intervention at time 1 or time 2. We had an outcome measure, which had been developed elsewhere to grab some of the kinds of elements of recovery that we've talked about before. The project had an interesting course in that we set out with a more somewhat conventional recruitment exercise, working through clinicians, inviting people to interviews, and to cut a long story short, it didn't work. And so we had what in change management you could describe as a burning platform moment. and what in sports metaphors I've had described as never change a winning game and always change a losing one. And so we looked at that recruitment. We looked at that recruitment process and the data collection process, made some changes, and it worked. And those involved changing, allowing, in terms of this involvement of consumers, it very much allowed people to bypass the clinicians and enroll themselves in the project, as well as streamlining a lot of the data collections and adjusting the financial incentives. So this was a project that ran through these years, 15, 17. It was, we trained staff across both public mental health services and some non-governmental organisations, and then did follow-up sessions. And we did, as I said, attend very much to the issue of the relationship between the trainers, and this was something that didn't work so well the first time we did the training, which flagged up some problems which we then ironed out over the course of the time between the step 1 and the step 2. And this is one of the interesting things about Step Wedge. They do give you opportunities in some respects for what you might call a large-scale pilot of the work. Satisfaction improved, and overall, unlike the Refocus study, we did get a positive result on the primary outcome variables, which was significant. And we also got typically non-significant but positive changes across 9 of the 10 other secondary variables, which of course is highly unlikely if there wasn't any effect. The timing was really tough. Public mental health services, in the period that we were doing this, it was in Bailey and Napthine administration, budgets were tight, and with the advent of the NDIS, there'd been huge and disruptive reform of mental health community support services. So it wasn't easy to get this study implemented. And actually, there was an interesting phenomenon that the baseline in the non-intervening services was actually drifting downwards with the impact of those changes, which Pulsar, however, managed to arrest when the training intervention was done. So we did this. We wrote a lot of. So we then worked on processing the data from this, and that obviously was complex. These studies, they're fairly complex to analyze, but we then went through the process of submission and acceptance in a high impact journal. But one of the important spin-offs of this was that this also created the opportunity that in the environment that we have had here at Dandenong Hospital for a long time, we managed to create an environment that had both researchers and clinicians in and out, and trainers, and also people with lived experience working in various different roles within the project. And this then created the both formal and informal processes that enabled us to incorporate these various perspectives into the project as it developed. But it also created opportunities for some of the consumers involved to lead some specific work, at which point I think I will pass over, Michelle, to you to take the story from here.
Thanks, Graham. Before I commence with my involvement with the project, I'd also like to acknowledge those people that have mental health issues and the carers that look after those people. I'd also like to acknowledge those who are affected by suicide and those bereaved. I think Graham's opening was fantastic around the issues that mental health consumers have faced, which is by no means parallel to our Indigenous people, but at the same time, it has been quite a journey. So I'll just tell you a little bit about my journey and how I came to be involved in the Pulsar project. So the job that I undertook was advertised. I was trying to think back exactly how long ago it was, but it must be 10 years ago. So we're talking quite some time ago. And I saw a job advertised where they were actually interested in somebody that had mental health issues to apply for this role, which was as a research assistant. And I still recall a conversation with my husband going, you can't go into an interview and tell them about your mental health issues. Like, you just can't do it. And that was off the back of an experience I'd had in another workplace where I'd been discriminated against when I had disclosed my mental health issues to them, and they put me on lighter duties as a result. And so the result of that experience for me made me think twice about how much I did disclose and how much I didn't disclose. But then I found, after accepting the job, which was as a research assistant, initially to conduct qualitative interviews with other consumers, which I'd had experience in, I found this experience to be quite the opposite. In fact, you couldn't even get more opposite to the previous experiences I'd had. So when I accepted this job, another opportunity came up, which is Pulsar Every Day, which I'll talk about in a moment. So I took on this role with another consumer research assistant, Laurel, and we both worked on this particular project together, which I'll mention the funding in a moment. But Laurel ended up leaving the role after about 3 months, and so I took on this Pulsar Every Day project. So now I'm hoping the technology works for me and I can get the slides to move over. Oh, we can, yes. Okay, so these were the people that were involved. So it was myself as a consumer academic, although I have to say I didn't necessarily consider myself as a consumer at the time because I had never even heard that word before. There was Helen Waite, who was, I actually think she was an occupational therapist, maybe she was a nurse at Monash Health in one of the continuing care units, and also Verinda Eden, who is the chief investigator and who actually got some of the funding for this. So the funding was provided by Southeast Melbourne Health Services and also Partners in Recovery. So it was only a fairly small grant. So we're talking $50,000. And the aim of this was to develop a resource that could be used by consumers. So the feedback that had come back was that consumers actually wanted their own resources around recovery. And so Laurel and I did a lot of Googling, as you do, to see if we could find what resources were actually out there for consumers. And what we found is basically there was very little 10 years ago in Australia. There was some resources from Scotland, a flurry of smaller resources from the UK, but pretty much not a lot was out there. So we really needed to develop something that was specific to the Australian sort of audience. So it was quite a process that we undertook, and because it was very much consumer driven, and also we wanted to make sure that we followed co-design and co-production principles. So Laurel and I, between the two of us, under the lead of Verinda, we had a lived experience advisory panel. Then there was myself and Laurel. We also had a consumer and carer focus group. And it was sort of a bit of a rotation sort of process, I suppose. It wasn't, we would consult lots of groups and then come back and then reevaluate, reiterate it, and then go back again for more consultation. So, of course, this took quite some time. Ooh, too far. So in the end, I ended up doing quite a few focus groups. So we had a couple of consumer focus groups, and they were actually held at PART, so Prevention and Recovery Centres, primarily because it was easier to get a group together, and also the family and carer groups, which were done in a community house. So those went for about 60, or I've got an hour and a half to 2 hours. So what we actually did was we developed some sample materials and took them along to the consumer and carer groups and asked for their feedback about what they thought about the samples that we'd created. And then we adapted those materials and took them back again. So I know I've presented this before around, well, how do you get a group of consumers together and how do you get them engaged to actually want to give their feedback? And my answer is, and if I'd have been doing the slides, I would have added a picture for this, is pizza is the answer. So pizza was the key to get these consumers involved. So we would go at around dinner time to the parks and we would say, okay, we're ordering in pizza. What pizza do you want? So family and Kehoe groups weren't as into the pizza as the consumer groups. I can't remember, good question. I can't remember if we remunerated them as well. I think we probably did, because that was very much a Pulsar thing, that most consumers were remunerated. But definitely I think the remuneration was not as interesting as the pizza was. So that's basically how we got their involvement. And even those consumers that were within the park setting at the time but didn't want to participate in the focus groups could still get the pizza. But what I found was that because we were all sitting around a dining room table, we're all eating, we're all having a chat about the materials, they naturally just became involved because it was interesting and we were having a good time and we were having a chat, and that seemed to engage them really well. Yeah. Sorry, this is not, oh, there we go. So these are the materials that we ended up producing, and some of the feedback that we got from the consumers were the original training materials for staff also had this image of times, and they really liked that, so we kept that. The other thing that they encouraged us to do was to actually colour code the book that we created. So we created a little handbook which goes through all of the components of chime, and so they wanted them all of the edges of the pages, kind of hard to explain over Zoom, the edges of the pages colour coded so they knew which part of the chime model that we were looking at. They came up with the consumer leaflet with it being a road and a journey, and so we took all of those on board, and these materials were produced as a result. So what we did next was, beyond just creating these materials, we decided that we've got this great resource now, let's actually take it to some consumers and actually try out delivering it like a small recovery type of course, or along with the handbook. So we had a discussion with an OT at Monash Health and went out to I can't remember which continuing care unit it was, but it's out towards the eastern suburbs way. Anyway, we took the book with us, and we had a closed group for 4 weeks. And what that involved was me facilitating a group of consumers, and I think there were about 5 or 6 in total, along with the senior OT, and then producing, well, it's probably better I show you rather than me trying to explain it. We produced this, which was our resilience shield. So as you can see, the shield was cut up into 5 parts, and each part had one component of chime, so connectedness, hope, identity, meaning, and empowerment. So I actually got the consumers just to take one section of the shield at a time, so they didn't actually get to see what the whole shield was. And I wanted them, we'd have a discussion around what does it mean to have an identity, what forms your identity, what does identity mean to you? And we gave them stickers, coloured pens, magazines to cut up, and everyone, including myself and the OT, completed a shield. And then at the end of the 4 weeks, the shield was put together, and then they had to come up with a motto for what they saw as being part of their recovery journey, or what all of these components meant to them. And that actually worked out really, really well. And I'll show you some of the feedback, which is hard because I can't see the feedback. Okay. So this one was like the whole picture. I couldn't see it until later down the track, but there are different aspects that were helpful. I'm not going to read all of that because I'm sure everyone can read it for themselves. Another one around myself was, I thought she was a good for the group because she's lots of experience along the same lines as we do, and she can relay to us just what those different experiences were. She's very polite, and when we have the mental problems, we're thinking, oh my God, that's a huge problem. But if someone explains it to you step by step and how to keep going, that's a huge help. The shield was quite popular. So I think the shield sort of helps you think a bit more along the lines of exactly what you might use in terms of recovery. So we spoke a lot about that as we're going through the process. So the whole idea of the group was, again, took morning and afternoon tea, depending on the time of day, and was to have a general conversation whilst completing the components of the shield. So the idea was that it was more of a conversational type of group as opposed to it being more of a formalised type of group. Again. So things that people learn. So it was self-empowering them to implement some of the ideas and reflect back on what had been learnt. Some of the definitions. So obviously it really struck a chord with some of them around identity, connectedness, empowerment. And then feedback from the staff that they said, and so we did have some other staff members would just call in and have a look and see what was going on, as people do. And their comments were that they felt it was really valuable work and they could see people opening up that didn't really talk much, and it was generally an enjoyable experience for them. So that brings me back to the title of today's presentation, which is around meaningful partnerships with mental health consumers. So I guess for me, the essence is literally in the title, which is around meaningful. So I think when working with consumers, you have to think about what is it that makes that relationship meaningful and how can you form that meaningful relationship. So for me, I think at the time when I reflect backwards, it was most certainly about addressing the power imbalance, or at least for the clinical staff or the academic staff being acutely aware of that. And I think it's a lot more common now when we think about addressing the power imbalance. I think people are more aware of it, but 10 years ago, mental health's come a long way in 10 years. I think the other thing for me was being treated as an equal, being involved in the decision making, so attending meetings and those sorts of things was really important to me. Having my expertise on it and skills on it as well, which is really important. I was also trying to do a PhD at the time. But I was also given a lot of opportunities, which thinking back, I really did appreciate. So I think at the time I must have gone to at least 3 or 4 conferences in the 2 years to be able to present the work. So for me, that meant there was a high level of trust in the work that I was doing. I was also given a lot of autonomy. So there was no such thing as being micromanaged. At Pulsar, it's everybody's ideas counted, as well as having some flexibility. So I think what that meant is, for me, I had a voice. I was not, as in my prior experiences, just a voiceless person who was discriminated against. It was quite the opposite of that. So as I mentioned at the beginning, I was involved in this project where I actually didn't even know anything about recovery. I didn't know what recovery-oriented practices were. I didn't even know what a consumer was. I was completely naive. All I knew was that I'd had mental health issues, and it was hard and it was a real struggle. But I think for most people now that know me and the work that I do will know that I'm a huge advocate for recovery-oriented practices, educating people around mental health, ensuring that stigma is addressed. And also I'd like to see a new era, I suppose, or new generation of consumers to be empowered and grow with the same opportunities that I was given, and I feel very lucky to have had. Such to the degree that the Pulsar training, we continued until we were still doing it last year with a not-for-profit organisation, which was myself and a Monash Health OT, Nita. And so we've continued to with that really great work, and people really enjoy that co-facilitation with a clinical person and a consumer background. So yeah, I think that's all. I hope I've managed to address the meaningful part of the partnership, but I'm happy, and I'm sure Graham is too, to take any questions people might have.
Well, I wonder, Michelle, thank you very much. And I wonder, just we can maybe take a couple more minutes before we throw open for questions, because there are 1 or 2 things that I'd perhaps like to reflect on. And one of them is this issue about the way that in doing the training, we had all this content, but I think that we reached a view, and I can remember some of the training that you and I did together, sort of road testing that when you were trying to encourage clinicians and other workers to work with consumers, provide care to consumers in a way that was different, in a way that more reflected a coaching and partnership approach, that one of the things that we reached a view in the project was absolutely critical was that the 2 people who were doing the co-delivery really walked the talk, as it were, on that, that there was an authenticity about that. Could you just respond to that,
Sure.
perhaps from your side?
Yeah, absolutely. And I think that comes back to the trust as well that I mentioned. So certainly I think when you're co-facilitating any training, there's got to be a certain degree of trust in what you're sharing. And I know for me, when I first did some of the pulsar training with Graham, I found that really challenging, to be honest, to share my experiences and leaving myself open and maybe somewhat vulnerable to sharing those experiences. But I think as I grew through that journey, it was actually seeing that as being empowering instead of being vulnerable, but also knowing that someone that I was co-facilitating with had got my back and that I'd got theirs as well. So it was not about coming in sort of like with opposing views. We were actually on the same page around what was needed. And I think the other thing that we acknowledged at that time, Graham, was around not telling clinicians how to suck eggs, basically. And we'd be completely upfront about that and say, you know, you do great work as it is. What we're trying to do is give you a more consistent approach with how you go about doing your work so that everyone is on the same page. And that it's not about necessarily doing things massively different. It's about doing it consistently. Did I answer your question there, Graham? I feel like I went off on a bit of a tangent there.
No, I think so. I think so. I think you've. I would hope that that's helped given a bit of a flavour of it. But I think that there are. I think that you know, and we're thinking about doing this in relation to some further training. I was actually talking with Mike Slade about this in relation to a French project which is working on this. And I think there are things. There are sort of micro skills rules like, you know, don't interrupt each other. Like, you know, so listen to people out. Like if you feel that you want to, you know, the way you go about handling disagreements or disputes in ways that remains respectful of the other person. And I think that the process of sort of maintaining that through the training was really very important in modelling to firstly the GPs and then the others involved. I wonder if I can just comment on one other thing that and invite your response on. I mean, one of the things that I think we did create during the years when we had that project going was we did create this environment helped, I think, by actually the physical space is I think is quite good. And fairly sort of permeable between the different levels of the hierarchy. Yes, there are some of us have offices and some are open plan, but there's a lot of glass and a lot of space, and so the senior people were pretty approachable, and there were fairly, you know. But I think that there was also a way that there were also sort of several consumers involved, so that there wasn't just one isolated person. So there was a degree of you know, of a sort of, you know, community support, and so I just wonder whether you've got, because I know that, you know, it's yeah, I just wonder whether you've got any comments on that as part of the process that you know.
Yeah, I think it was a strong team regardless, and I think it was a very flat structure, and so I don't really see that. It didn't really matter what you came in or what your role was. I think everyone was treated the same, going for lunch together, going getting morning coffee. And probably the most memorable moments was Geraldo and the journey of Geraldo. Geraldo was our little stuffed animal, and I can't actually remember what the animal was, but anyway, Geraldo was our team mascot that would go on holidays with whoever was going on holiday and have photographs taken in amazing places and was shared with the team. But I think it was small things like that that actually made you feel part of a team and brought us all together about a stuffed toy called Geraldo who went travelling. And so I think that that sort of helps in a team environment as well, where you don't really necessarily have to go, well, you're the consumer. And I think often consumers can feel their involvement is very tokenistic. Oh, Wombat, thanks Thanks, Graham. I couldn't remember what Geraldo was. I think often consumers can feel like their involvement is very tokenistic. I most certainly never felt my involvement was tokenistic. In fact, I feel like it was quite groundbreaking at the time. So it's not, I think it's something you would have to do very mindfully. I'm not sure it would just happen. And I think I was just very lucky.
Yeah, look, it's nice of you to conjure away. The project actually had a whole range of stuffed toys. Which,
yes, I didn't mention the qualitative.
Yes, the qualitative research group. There was the project implementation group and their mascot pig. So yes, and these probably are actually, you know, important sort of congeners, important sort of supports for the whole process. We did say that at this point, around about now, we would try, Angela, to open back up to questions, and I see there's at least something there. So we'll so unless, Michelle, you've got anything else that's burning.
No, but I'm quite happy to respond to the question from Ashley about being vulnerable to get participants chatting, and was there any additional support offered for you for your own mental well-being or strategies you put in place to reduce additional harm through triggers for yourself? I think, again, this came back to the team that I was a part of. There was a psychologist within that team, so that's definitely a person I could have talked to. I didn't actually feel the need to seek additional mental health strategies for myself, probably again because we were such a cohesive team, and I could easily go out with one of the other project staff and just have a chat if something had come up. But I actually never felt I never felt at risk, and I never felt triggered by what I was sharing, because I was with other people that had the same or similar sort of dilemmas. And so, in fact, it was quite the opposite. It was actually quite an empowering experience of being able to share what I had been through and be able to go, you know, I can put these strategies in place and I can actually get better, or not better, but I can do better, and I can do valuable things with the experiences that I've had. So for me, no, but I do think it would be important for that to be sort of at the forefront of someone's mind if they were engaging with consumers.
Thanks so much, Michelle. And Ashley's just agreed, having a supportive team and environment is absolutely critical. And I think everything that you've talked about creating this very safe, supportive team where everybody can contribute and everybody's contribution is equally valued, be you a clinician, a researcher, or someone with the lived experience of a mental health condition. And I thought throughout your presentation, Graham and Michelle, there were just many beautiful examples of how you did that in a very genuine way, co-partnering around delivering of training. Some of the cues that you picked up, Graham, about things that we just need to be very mindful of is, you know, how we speak when we're with other people, about some of those kind of common courtesies, which are just absolutely just so important in terms, I think, of people feeling that they're equaled and that they're equal contributors to a bigger effort. I can see another question there. Around, just open it up for a moment, from Kathy, were you able to engage people from diverse cultural backgrounds in the context of this research, or do you have any experience or suggestions? Often that's an enormous challenge, as you would both know, getting that diversity of engagement.
Yeah, shall I have a go?
You go, Graham. Yeah.
There was. I mean, I guess that the project was set across the various mental health teams in Monash Health, which is an area that has considerable cultural diversity. There was quite a degree of, and so there was quite a degree of recruitment into the study from people from a range of backgrounds. And indeed, there's a paper just making its way towards publication, looking at the QPR, the questionnaire on the process of recovery, and some aspects of cross-cultural of cross-cultural validity. And this is something that there is more to go. And I think that there, of course, is the issue about, you know, cultural and linguistic diversity in relation to, you know, different ethnic or national groups. But there's also the issue of, you know, what of socioeconomic disadvantage and the levels of, you know, of economic and often intergenerational deprivation that you have. And of course, Greater Dandenong, which was one of the major sites, is the most socioeconomically deprived metropolitan area of Victoria. So, you know, and that was part of the ground for it. So yes, you know, we did do some of that, but we are continuing to look at opportunities for going further in that direction.
Thanks, Graham. Jessica has a question. She's just acknowledging the wonderful work that you've done to date and is interested in what the next steps are for Pulsar. Do you think there's a possibility for larger systems change around mental health systems with this model?
Yeah. Look, I mean, I'll try and start off talking to that. There's a huge challenge here when you do a study like this, that obviously there's a lag between the work and the publication. There's then, and in that time you have huge, you know, cultural and staff turnover in host organizations, and then there is another lag before you start getting demand for the training, and in between that you have to try and maintain a team that can still deliver it, but actually we do now have, as you know, Michelle related to, we have had some non-governmental organizations particularly who've come to us and asked us to do training for them, which has helped keep some of that continuity. We are now in discussion with the Centre for Mental Health Learning centrally in Victoria about them funding some more training. We did do some of that through the cluster, and we're looking at further opportunities in the context of the Royal Commission recommendations and of and also of, you know, I've already got one or two, you know, and we'll be exploring soon possibility of another MRFF submission to try and advance the work. So, you know, yes, it's great that people, you know, feel the work is there. It's hard work doing this follow-up stage of trying to sort of move it on and get adoption.
Can I also just add to that, Graham, just because I can spruik a bit of business. Monash University, we're running an undergraduate mental health course, which is 4 units. And I actually teach the recovery unit, which is based on Pulsar. And there are Commonwealth supported places for that course. So I know someone asked a question around primary care and community, and if there's a way of providing learning for these services. I'd highly recommend that course. It's pitched at below undergraduate level. So it's 4 units on the basics of mental health generally, and mine's a 12-week unit on recovery.
Thanks, Michelle. There's just another acknowledgement of some of the valuable lessons from today's session, but a question if the consumers were volunteers or paid, and do you find this design is beneficial in a way that consumers feel they get something out of it too, and there's something beneficial in it for them, and not interested in paid work so much?
Well, they did get reimbursed by way of gift card. I certainly felt, because I did all of the qualitative interviews with the consumers as well, I think they really valued the opportunity to talk about their experiences of the mental health system, their experiences with the service provider. And even though they were reimbursed, a lot of them would always say to me, I'm not doing it for reimbursement, I'm doing it because it gave them a voice. Like it gave me a voice, it gave them a voice to be able to share their experiences. So yeah, so I think that's why a lot of them, you know, did participate. And there was a second part of the question. Do you understand?
Yeah, a quick question, just going back to the course or the units that you mentioned, Michelle, just around, can they be done independently, or is it
Yes.
a whole program?
No, you can do just one unit if you wish to, or you can do all 4 to actually get the certificate. You would need to do the 4 units because it's actually called the Undergraduate Certificate of Mental Health. But yes, you could just do the recovery unit if you wanted to. There's also, for those that are qualified and already have a degree, there's a single bachelor's unit, and I'm in the throes of just writing a master's unit as well. So there's something to suit everybody.
Fantastic. Michelle and Graham, we're coming up close to the end of our session today, but I wanted, given your experience working together, what have been your kind of greatest learnings out of working together in this particular way, so in such a meaningful and effective way? What are the kind of the most important things that you would want to convey to perhaps someone who might be online today, or possibly listening to this session later on and thinking, okay, I really want to work in this with consumers closely, I don't have experience in it. What have been your greatest learnings out of your work together?
Oh gosh, I think that's a really hard question, Angela. I think a lot of it sometimes comes back to whether you're a good match with the person. I think that helps. I think you've also got to acknowledge that it may not always go smoothly and there might be challenges, and Graham and I certainly have had our challenges over those numerous years, but it's been able to sort through those challenges like you would in any working relationship. Certainly for me, I think it was around being treated as a valuable person and not being talked down to in any way, shape or form, but being treated for the person that I am, and that having had a lived experience does not make me a lesser person. But I think that was the philosophy of the team generally. So I don't think it's something that you can learn necessarily. Oh, maybe you can learn it, I don't know. But I think it was a philosophy that Graham had instilled in the entire team. So that was just the way we worked. So, and I think you need a good leader to be able to do that, to model that behaviour.
Yeah.
Yeah, look, thanks for that. It is indeed a good question, and Michelle, thanks for those responses. I guess one really does need to think about it in a quite sort of systemic, networked way, and think about a range of overlapping issues. There's the issue about the employment conditions that people are on and being sensitive to what that means. There is the issue about respecting consumer time, involvement in the project with remuneration. There's the issue about the way that as Michelle said, the way that there is not a sense of undue hierarchies in it, such that there is a mutual respect across both, that the people who are there with lived experience roles and the people with professional and academic backgrounds. So I think that one needs to think about, there's a range of things that need to be held in balance, and then there is the ambience and the ground rules and the ways in which the team work together, and consider extending the team with some cozy, friendly little fluffy toys. The plush toys, they have their benefits. Sometimes you may find that people throw them at each other, but at least they're fairly small and squishy and don't do any lasting damage.
Graham and Michelle, look, our sincere thanks for your presentation today. You've talked about your work in a mental health context, but everything that you've spoken about has very broad application, irrespective of the clinical domain. I think we appreciate your generosity, the work that you're doing. Everybody online is very appreciative of your insights today. Thanks to everybody for joining. We'll engage with our speakers and hope to be able to make a copy of the webinar available. And Michelle and Graham, thank you from the Monash Partners team, and thanks everyone for joining us today for our session. Just fabulous to hear about the work that you've done together, and most importantly, the way you've gone about it. Really impressive.
Thanks, Angela.
Thanks so much, everyone.